Hi guys, so welcome back to my channel Dr. Z the AIIMSified WombWhisper. So in this video we will be talking about partograph in AIIMSified and simplified way. Okay, so you need to know two graphs by details because it comes both in your theory and practical exam, and it is very important in our practice also for those whoever is involved in care of laboring patients, those who are willing for normal vaginal delivery. So let's go back. What is a graph? As you all know, graph is representation of something against time. So what is partograph? Partograph is graphical representation of progress of labor against time, and along with that there is monitoring of both maternal and fetal conditions in the graph. And what are the objectives of partograph? Because it shows you how a labor progress. So if there is any abnormality in the progress of labor, you can just know from the graph. So for early detection of abnormal labor progress, and if the labor is prolonged, if it is not at a desired rate and it is getting prolonged, so there are many complications of prolonged labor. So we can prevent that by prevention of prolonged labor itself. We can identify CPD, pelvic disproportion, because if there is CPD there may be prolonged labor or abnormal progress of labor, and with CPD there can be obstructed labor if not managed within time. So if there is CPD or there is abnormal progress of labor or any signs of obstructed labor or whatsoever, that can be identified from partograph, and we can very well intervene within time, and we can save mother and baby, and we can give a healthy baby to a healthy mother. Okay, so this is very important. Also, partograph acts as an early warning system, and it aids in timely decision. If patient is in a lower center, we can refer her to higher center, tertiary care center whenever needed. So in timely decisions of transfer, if augmentation of labor is needed or termination of pregnancy is needed, all that can be known from the partograph, from the progress of labor. It helps in early recognition of maternal and fetal complications. So why partograph is very important? Because it helps us in early detection of abnormal progress of labor and prevention of prolonged labor, and then it significantly reduces the risk of postpartum hemorrhage, sepsis. It eliminates obstructed labor and thereafter uterine rupture and its sequelae. Okay, so why I am telling you all these points? Because in theory, if it comes in theory exam as a short notes or a long question, you can write all these and you can very well cover your answers. So how partograph came, evolution of partograph. So first there was this man Friedman in the year 1954. He gave us latent phase and active phases of labor. He told us that there are two phases of labor, latent phase and then the active phase. In active phase we have acceleration phase, phase of maximum slope, and then deceleration phase. And he told us that active phase of labor starts when the cervix is dilated more than or equal to 3 centimeters. Okay, so first came composite partograph. In composite partograph, you can see it is similar to modified WHO partograph, but this was much before than whatever partograph we have now. So here you can see there is latent phase, okay, and then there is active phase, and the active phase begins when the cervical dilatation is 3 centimeter, and you can see here is rows for fetal monitoring, labor monitoring, maternal monitoring. So this is what composite partograph was. It came in 1988 and it was first partograph based on WHO model. It was updated in 1994. Here latent phase, as you can see, is of 8 hours. An active phase has been started from 3 centimeter dilatation, and this is the alert line and the action line. It is at a rate of 1 centimeter per hour, and the the difference between the alert and the action line is of 4 hours, and the action line is to the right of the alert line. Then after composite partograph came modified WHO partograph. It was modified in the year 2000. Here, so in modified WHO partograph, we can see that there is no latent phase and the active phase starts from 4 centimeter. It was modified in the year 2000, from which latent phase was excluded. And why it jumped from 3 centimeter to 4 centimeter, you know, the start of active phase, because it was made to maximally decrease the risk of intervention, because in multiparous patients already their cervix is spatulous and one to two fingers dilated, so it will lead us to unnecessary intervention in those patients. So that is why the active phase has been started from 4 centimeter. Then there was simplified partograph. It is same as modified WHO partograph except the color coding. You can see this is the alert line and this is the action line, and then the zone has been divided into three. Zone green is where the labor is progressing normally. Zone yellow is when the labor is slow and we need to make some conservative measures. We have to make some corrections so that the labor can go back to normal progress. But if not, and if it becomes more slow, then it will come and fall in the pink zone, and then we have to take action and decision for termination of pregnancy. Similarly, you can see the fetal heart rate zone has also been color coded. The white is where it is falling within the normal range and the red is where the heart rate is abnormal. It is mainly used by the skilled attendants in healthcare facility. For them it is easier to identify when the labor is going wrong or right, rather than just following the graph. Then the latest one we have is WHO Labor Care Guide. It in 2018, WHO published some new recommendations for intrapartum care for positive childbirth experience, and based on evidence-based practice, obviously. And then it implemented some new recommendation based on the above things, and the design of the partograph was changed, and now it is being called as Labor Care Guide. So it looks like this somehow. It has 7 sections. It looks like this. So you need to know both modified WHO partograph well and this labor care guide well, and both cannot be covered in one video, because LCG is new, and there are many sections. So I'll take this labor care guide in next video. In this video I'll only talk about WHO partograph, modified WHO partograph. Okay. So this is how modified WHO partograph looks, and it has 3 parts. In top you can see there is fetal well-being. In middle you can see there is progression of labor, dilatation of cervix and all, and these medications. And in the bottom there is maternal condition, pulse, BP, drugs, and etc. So what are the advantages of partograph? So once again it may be asked in your practical exam, and you can write it in your theory exam also, in your short notes and long question whenever it comes for partograph. So what are the advantages? It provides us with key information at a glance. So in a sheet of paper only you can see how the labor is going, how the maternal and fetal conditions are, if you need any intervention or is it all fine. So in a paper only you can see and have a look, and you will know how the labor is being progressed. Okay. It can distinguish between normal and abnormal progress of labor. It can help us in predict deviations early and give us time for timely interventions, and it facilitates smooth staff handover. So during handover of our duty, we can just show the staff this graph, and this is how the labor is going on, and it is easier for both of us to make them understand, and for them to understood whatever they are telling, the handover staff is telling. So there are some principles while plotting partograph, and you should follow this. I am talking about modified WHO partograph only in this video. Okay. So active phase begins from 4 centimeter dilatation. I have told you why already, and the rate of dilatation, expected rate of dilatation is 1 centimeter per hour, and there is 4-hour time lag between alert and the action line. Why? This is one of the questions of practical, because before any intervention, when it touches the action line, we have 4 hours lag time, which is safe for both mother and fetus and helps avoid unnecessary intervention. So suppose if there was only one line, alert line, you had taken some decision then and there only, then we might not have known, okay, with conservative measures also labor can be, when it was slowed, it can be back to its normal progress. So alert and action line is made for us to prevent these unnecessary interventions. So in which cases will you be using partograph? So partograph can be used in all patients undergoing vaginal delivery to monitor their labor, but in high risk patient, obviously there are some additional monitoring and support and care. Okay, but in low risk patient, always we use partograph. So I will talk about partograph in parts. In first part, you can see there are some patient details: name, gravida, parity, hospital number, date of admission, time of admission, ruptured membrane. So time of admission is something, and patient had already come with ruptured membrane. You here mention the actual time when patient had complaint of leaking, at what time had leak started. And suppose if patient is admitted, till then there is no rupture of membrane, but after admission she is into spontaneous labor, there is progression of labor, and then suddenly there is spontaneous rupture of membrane. So you mention that time here, when there is spontaneous rupture of membrane or when you have made artificial rupture of membrane, you mention that time here. Okay, so this is patient particulars first, and then comes the fetal part. Here you can see fetal heart rate. Okay, so fetal heart rate range is given here from 80 to 200, but the normal range which we take is 110 to 160, up to 100 to 180 is also there. The marking is there for 100 and then 180 in some partographs. So this can be considered the range, but this is the best. When asked, you can say this. Then comes amniotic fluid and molding. So if there is rupture of membrane, how is the color of the amniotic fluid? And if the membrane is not ruptured, you mention amniotic fluid as I. I means intact membranes. Okay, and suppose if there is rupture of membrane, then what will you write? If the fluid is clear, you can write C, clear amniotic fluid. If it is meconium stained, you can write M. Okay, and if it is blood stained, as is in abruptio placenta, you write B when it is blood stained. Then comes molding. So what is okay? So molding can be no molding, or it can be 1 plus, it can be 2 plus, it can be 3 plus. Right? What is molding? So molding is when the skull bones of the baby touches or glide over each other, mostly the two parietal bone, when the baby passes through the birth canal. So if there is no molding, you just cross it. If there is molding and it is 1 plus, 1 plus is when the bones touches each other. Grade 2 is when the bone overlaps with each other but it is easily separable, and grade 3 is when the bone overlaps each other and it does not separate. Okay, so whatever the type of molding is, you just write it here, no molding or 1 plus or 2 plus. Okay, and molding only you will know when you do per vaginum examination. Then comes the labor progress. When the progress of labor touches the alert line, you become extra vigilant. You see how the contraction is, how fetal heart is, and you just give extra care so nothing goes wrong after that. And when the progress of labor touches the action line or it crosses the action line, you just don't wait now. You just at this point, this is the critical point, and you take the management decision whether to apply forceps or to go undergo cesarean or to transfer to tertiary care center or whatsoever. Okay, and then comes a cervical dilatation. So it is marked as cross, and the descent of head, it is marked as round. So First, whenever the patient is coming, suppose patient is coming at to you at 1 p.m. or suppose it is coming at you by coming to you by 1 p.m. So the hour is 1. If patient is coming at 8 p.m., still here the hour is 1. First hour when you are starting the plotting. Okay. So you mention the actual time here, 8 p.m., 9 p.m., 10 p.m., 11 p.m. and so on. And then here this is the hour given, and the first plot will start only when the cervix is 4 centimeter or more dilated. Suppose a patient came with complaint of pain abdomen and you examined her and she is in labor, but when you did PV examination, cervix is only 3 centimeter dilated. So you will not start plotting at that time. You will start plotting when cervix is more than 4 or 4 centimeter dilated. Okay, got it? And you first start plotting on the alert line only. So your first plot will be on the alert line. Suppose a patient is coming to you at 6 centimeter dilatation. So what will you do? I'll show you. So 6 centimeter dilatation is here. This is 6 and it is falling on here. So you will plot here, and your first hour will start from here, and whatever the actual time is will start from here. Okay. So this is how you plot. And the descent of head will go from 5 4 3 2 1 0. So you do abdominal palpation and you see how much of the fifth is fetal head palpable. Is it 4/5, 2/5 or 1/5 or not palpable even? That I have told you in obstetric examination chapter, the video, how to do abdominal palpation in that case. So descent of head you make out by abdominal palpation. And it is confusion sometimes whether descent of head we plot by when we know the station by vaginal examination, but it is by abdominal palpation. Okay, sometimes I also forget it, but it is by abdominal palpation. So suppose when it was 5 centimeter dilated or 6 centimeter dilated, in that column only you plot the descent of it. Suppose the head was 2/5 palpable, so you plot it as here. Okay. Then after cervical dilatation and descent of head, there is abdominal palpation. On abdominal palpation you will look for contractions. And how do you plot contractions? So there is mild contraction, there is moderate contraction, and there is when it is all dark, it is good contraction. So mild contraction lasts for less than 20 seconds, moderate for 20 to 40 seconds, and good is more than equal to 40 seconds. So we need at least 3 contractions of good intensity for a labor to progress adequately. So in this, there you can see 5 box. Why not more than 5 box? Because then that will become hyperstimulation. So there should not be more than 5 contractions in 10 minutes. Okay. So suppose here at this patient came with 6 centimeter dilatation and there was moderate contractions, 3 contractions of moderate intensity in 10 minutes. So here I will fill 3 boxes. So the number of boxes is equal to the number of contractions, and the shading will be according to the intensity of the contraction. Okay. And this one box is of half an hour. You can see this whole box is 1 hour and this half box is of half an hour, 30 minutes. Okay. And then down the line you can see there is oxytocin in unit per liter and drops per minute. Suppose 2 unit per liter is going, so you write 2, and drop is suppose 16 drop per minute, so below you write 16. Okay. So whatever is going, you just write the unit and the drops per minute below that. If no oxytocin is going, you need not write nothing, you can just leave it. Now in the third part there is drugs given. If you are giving any additional drug to the patient, suppose a patient is a GDM on insulin, if you are giving her insulin or DNS with regular insulin, whatever you are giving, or there is some electrolyte imbalance, you are correcting that, or you are giving hydrocortisone for some reason, or whatsoever, you just mention it here in this column. And then there is BP and pulse rate. So BP you do it like this. Suppose BP is 120 by 80. So 80 is here and 120 is here. So you just mark it both the point and then draw a line and connect it. So this is BP, and suppose the pulse is 100. So you mark it as 100, or if the pulse is suppose 70, you mark it here as 70. Okay. Here you mention the temperature, and then you do urine dipstick below. So pulse you need to take at least every 30 minutes, and others 4 hourly. But suppose a patient is of preeclampsia, you cannot leave BP for 4 hourly monitoring. You then need to monitor it more frequently. This is why I told earlier that you need additional monitoring in high risk patient, not only partograph. Okay. So this is how intrapartum monitoring goes. In first stage, in low risk patient, you monitor fetal heart rate every 30 minutes. In a high risk patient, every 15 minutes. In second stage, you look for fetal heart rate every 5 minutes in low risk patient, and in high risk patient there is continuous CTG monitoring. Okay, and each auscultation should last for 1 minute at least, during 30 seconds during contraction and 30 seconds after contraction. Why just after contraction also you need to know the fetal heart rate? To pick up late decelerations. So to pick up late decels, you need to hear the fetal heart sound after contractions also, 30 minutes after contraction also. And as I told, in maternal monitoring, you do pulse monitoring every 30 minutes and other vitals every 4 hours. And uterine contraction monitoring in first stage you do every 30 minutes, as in here the block is of 30 minutes only. And in modified WHO partograph there is no place for second stage monitoring, but in WHO labor care guide there is that place. So just for your knowledge sake, every 5 minutes we check for contraction. And in second stage, so obviously the number of contraction will increase, so just remember this one. Vaginal examination will perform 4 hourly, and descent of head is assessed abdominally every 4 hourly. Okay. I have given some examples of partograph. So in exam what will be done, they will give you one partograph, field partograph, and tell you to interpret. So when you start interpreting, just start from above. See at what time patient was admitted and if there was any rupture of membrane. Then look for the fetal heart, if it is within the range or not, if the amniotic fluid is clear, if there is any molding, if the labor has progressed normally, if the contractions were adequate, and any other medication or BP pulse are normal or not. So when you start interpreting, you have to look for every sections of the partograph. If anything is wrong in the partograph, you have to tell that. Otherwise you can tell that okay, fetal heart rate was in the range between these and these, and there was a rupture of membrane at this time, and then the amniotic fluid was clear and labor progressed normally, and all that. Okay, so in this example I have given you, the patient is G2P1L1 at 39 weeks and 4 days period of gestation. She came with complaint of leaking per vaginum along with pain abdomen since 4 a.m. this morning. So on 23rd of September, patient had pain abdomen since 4 a.m. and when she came to hospital and admitted at 8 a.m. Okay, and patient had leaking and pain abdomen since 4 a.m. So here 4 a.m. is mentioned. So you see her progress of labor. She when vaginal examination was done, she was already 4 centimeter. You can see patient was admitted at 8 and then examination obviously will be done thereafter. So examination was done at 8:30 a.m. This is the first hour and she was already 4 centimeter. So it is plotted on the alert line, and the descent of head is plotted as 3/5 palpable. So the head was 3/5 palpable. Then 4-hourly it was checked. As you can see, at 12:30 p.m. after 4 hours, the labor progressed quite well. The pervaginally the cervix was 9 centimeter dilated and the head was not palpable anymore. Then within 1 hour more it was fully dilated. Okay, so the labor progressed normally, and in this section you can see the contractions. Initially it was mild and then oxytocin was started, then it became moderate and then good contraction, and patient had delivered at 1:50 p.m. Here you can see by 1:30 p.m. she was fully dilated, and then by 1:50 p.m. she delivered. Male baby this many kg Apgar and baby is mother side. Okay, so this is how it will be plotted. Here BP pulse will also be plotted in your final graph. So this is how the case will be given to you when you need to interpret. This is another example. Here Mrs. A is primigravida at 38 weeks and 6 days period of gestation. She came with complaint of pain abdomen since morning. At 6 p.m. When she was admitted, per abdomen there was mild to moderate contraction, and per vaginally she was 3 centimeter dilated. So I told you you start plotting only when the cervix is 4 centimeter dilated or more. So you did not started plotting here. So after 4 hours again examination was done, and she was found to have a moderate to good contraction, along with her cervix was dilated to 5 centimeter. Now you start plotting in this case. So I told you the first plot will always be on the alert line. So here you can see at 5 centimeter it is plotted on the alert line, and the head is 2/5 palpable, so you plot it here also. And then after 4 hours we can see that the labor was not going quite well. Then her contractions were also becoming mild to moderate, and then oxytocin was started. Her contractions became good, and patient was then fully dilated, and she delivered a healthy female baby. Okay. So this is one of the conservative measures. Suppose labor is not progressing adequately, you saw something is between the alert and the action line, so you see everything. If fetal heart rate is good, if there is meconium aspiration or what, if contraction is adequate or not. Here we saw that the contraction is not adequate, so the labor is not progressing adequately, so we started oxytocin. Once we started oxytocin, there was good contraction, and then labor progressed. Okay, so this can be one of your examples in your exam graph in your exam. And here what I have shown is, see, at 4 p.m. in first hour cervix was 4 centimeter dilated. Okay, then after 4 hours again PV examination was done. Cervix was then 6 centimeter dilated. It is not 1 centimeter per hour progression, it is slow progression, so it came between the alert and the action line. And as you can see here also, descent of head is not there, head has not gone down. Okay, then you already had started on oxytocin for contractions. So even after patient is getting adequate contractions, at some point there was hyperstimulation at this point. Here what you did, you see here you have stopped oxytocin. So when there is hyperstimulation, one of the conservative measure is you stop oxytocin, then you make the patient left lateral, you provide hydration and oxygen if required, if saturation is falling. Okay, or if there is fetal distress. So you stop oxytocin here, and then again after 4 hours when you examined, there is no progress of labor, it is still at 6 centimeter. So now it has crossed the action line. Now you have to take the decision. So we had planned this patient for lower segment cesarean section. Okay, so this is how we manage a patient from partograph. Here you see now there is hyperstimulation, so oxytocin was stopped, and then we gave RL to the patient, fluid to the patient, to wash out the oxytocin from the receptors on the uterus. And also you look at the fetal heart rate when the labor was not progressing. There was some problem, maybe CPD was there or obstructed labor was there, something was there, that is why this happened. Fetal heart also was more, so there was tachycardia also. Okay, and molding also increased. It was 1 plus and then it went to 2 plus. Here you see I have written I means intact, memory was intact. At this point maybe ARM was done at 8 pm because progress was slow, so you did ARM, and there was molding 1 plus was there, and it was meconium stained grade 1, and then grade 2 it became grade 2, and molding also became grade 2 thereafter. So decision for cesarean was taken. Okay, so this is how we plot partograph, this is how we take decisions from partograph, and this is how we can prevent complications for partograph. So you should know it, we all should know it, and we should not mess with this topic also. So see, I am trying to cover topics in a way so that it helps you both in theory and practical exams, and it helps us in our general practice also. And it is important. This is very much important topic for every one of us. For me as an SR, for you as a JR or an MBBS student, as an intern or a nursing staff. So just whatever doubt you have, then you can ask me in the comment section. Please like and subscribe to the channel for more videos. In the next video I will talk about WHO labor care guide. Okay, so please like and subscribe to my channel. Thank you.